This is Dr. Mimi Lamb from Metro Health Medical Center, and I would like to explain how you can tell whether a patient has acute or chronic kidney disease. Say you meet a patient with a serum creatinine of 10. How do you know whether you're looking at the result of an event that damaged the kidneys a week ago or the result of years of CKD? In this situation, there are some questions you can ask and clues you can look for, so here are 10 of them in roughly the order that you would think about them. First of all, what does the history suggest? Is there an obvious precipitating event for AKI, a drop in blood pressure, or massive fluid loss, or history of an exposure to a med or a toxin, such as radiocontrast dye, or aminoglycosides, or ACE inhibitors, or NSAIDs? Or is there a history of an underlying chronic disease that is known to damage the kidneys, such as diabetes or hypertension? Second, what symptoms does the patient have? A patient with AKI often looks and feels ill with symptoms like nausea and vomiting or fluid overload. Patients with CKD may notice only nonspecific fatigue or decreased exercise tolerance. Third, what is the patient's baseline and/or most recent serum creatinine? Check previous hospital records or records from other hospitals, which may be available electronically. Previous physicals or labs done for insurance, employment, or sports may also provide important clues. Has the patient noticed a decrease in urine output? In AKI, the urine output often drops abruptly, sometimes to zero. Patients with CKD usually maintain a fairly normal urine output until late stages of their disease because their damaged nephrons try to compensate for decreased filtration by decreasing their reabsorption of solute and water to try to maintain sodium and water balance. Another important clue that CKD patients usually give is a history of long-standing nocturia because their damaged nephrons are unable to concentrate urine at night the way normal patients can. What's the patient's hemoglobin level? In AKI, it's often pretty normal because the red cells that are already there can last for up to 120 days. In CKD, the hemoglobin is usually low, suggesting that the patient may have been in a low EPO state for years. How's the serum potassium? No GFR means no potassium secretion, plus AKI patients may be catabolic and breaking down tissue, releasing potassium. Patients with CKD make gradual adjustments in tubular function, allowing them to excrete fairly normal amounts of sodium and water until very late stages of disease. So as long as you have even a little GFR and can reabsorb sodium in the collecting tubules, you can probably secrete potassium. What does the urinalysis tell you? In AKI, there is usually little protein, especially if it's ATN, but there may be cells that suggest cell death, like renal tubular cells, or signs of inflammation, like red cell casts. In CKD, there may be lots of protein in the urine, but oftentimes just nonspecific granular casts. How do the kidneys look on ultrasound? Are they big and plump and dark because they haven't had time to shrivel and scar? Or are they obstructed with a dilated collecting system and hydronephrosis? Or are they small, shrunken, and echogenic, suggesting years of progressive irreversible fibrosis? Once you've had time to observe the patient for a day or two, note whether the serum creatinine is stable from one day to the next or whether it rises daily. In AKI, the GFR can drop to zero in a very short time, while creatinine continues to be produced by muscle at the same rate, so the serum creatinine rises daily. In CKD, the GFR drops in a small stepwise fashion, and each window of time is a mini steady state with a constant serum creatinine. And finally, how's the serum parathyroid hormone level? Is it normal or nearly so because there's been no time for it to change? Or is it in the range of several hundreds to thousands, suggesting years of decreased synthesis of 1,25-dihydroxy-D3 by the failing kidneys, leading to hypocalcemia and stimulation of the parathyroids with chronic bony changes? In summary, The patient with AKI has experienced an abrupt decrease in renal function, often associated with a single bad event, and is usually symptomatic and ill. The patient with CKD experiences a gradual loss of renal function over the years, and the nephrons and the patient have had time to adjust to the gradual biochemical and physiologic changes so that the patient may have minimal symptoms but will often have lab abnormalities that provide a clue to the duration of their disease. In the end, do your best to use your clues, but remember that nothing's 100% and patients can fool you every day.